And it's very important to understand about this ApoE and its alleles. There are different types of ApoE alleles existing in the population. We have ApoE3, which is supposed to be the neutral allele, which is not associated with any health risk as well as health benefits. And we have another variant allele called ApoE2, which has having a little bit of lower LDL affinity and lowest receptor binding among all the other alleles. And it is not concretely proven to be associated with any health risk. Previously, it was thought to be associated with Parkinson's disease. It's been implicated by various studies in both increased as well as decreased atherosclerosis, but right now, forget about ApoE2, that's all. And then we have a third type of allele called ApoE4, and this is the most important as far as our clinical understanding, because this is having more LDL affinity, more receptor binding. At the same time, this allele is going to result in increased risk of atherosclerosis as well as other diseases like Alzheimer's disease. Apart from that, they are also associated with poor prognosis after some conditions like traumatic brain injury and multiple sclerosis. But anyways, the most important exam question is on Alzheimer's disease and its association with ApoE4, pretty important for exams. We have discussed about this lipoproteins and apolipoproteins in detail. Now we'll move on to the etiology of this lipid disorders and dyslipidemias. Etiology wise, first you have to know about the Fredrickson classification. So we generally call this as Fredrickson phenotypes, and very commonly an undergrad usually thinks that this Fredrickson classification and Fredrickson phenotype is only for familial hyperlipidemia. No, it applies for both familial and acquired. So basically it's like grouping the lipoprotein disorders and lipid disorders, that's all. It's like a classification of lipid disorders. So we have 5 Fredrickson phenotypes, 1, 2, 3, 4 and 5. So 2 can be divided into 2A, 2B, 3, 4 and 5. So 1 is basically a problem of chylomicrons, which means patients may have a normal cholesterol, but the patient will have an elevated triglyceride. That's what phenotype 1 is. Phenotype 2 is basically a problem of LDL, which means it's a cholesterol. LDL is a type of cholesterol only. And you have a high total cholesterol here and a high LDL. High LDL means I can also write increased apolipoproteins, clear, ApoB proteins. And 2B will have a problem of both LDL and VLDL, which means patients may have increased LDL, that is increased ApoB more than what you see in normal individuals, and they may have an increased triglyceride because of increased VLDL production. VLDL means triglycerides only, increased VLDL. At the same time, the total cholesterol may be surprisingly normal in many patients. We don't know why, but remember, total cholesterol is variable. That's why I'm going to write. It can be increased and normal. That can be normal in certain patients. And 3 is what we refer to as something called a remnant disease, where the patients will have increased remnants. There are 2 remnants I'm talking about. One is the chylomicron remnant and second is the VLDL remnant, that is otherwise called as ideal. So if the remnants are increasing, obviously your total cholesterol will increase and your triglyceride also will increase. Clear? So what about type 4? Type 4 is a problem of VLDL, increased endogenous production of VLDL, where the patients will be having elevated total cholesterol and elevated triglyceride, plus or minus low HDL. This is the biochemical representation of this type 4. And type 5, patients are going to have problems with chylomicrons as well as VLDL. Obviously, the patient will have elevated triglyceride in this disorder. So these are how you classify. These are the Fredrickson phenotypes. Remember, either a familial dyslipidemia can come under one of these Fredrickson phenotypes, and your acquired dyslipidemias also can come under one of these Fredrickson phenotypes. This is just a phenotypical classification of your lipid disorders. That's it. Now, as such, the etiology as such can be broken down into familial causes or primary problems or secondary causes. So first, let me tell about the primary problems, primary dyslipidemias, and we can also think about talking about secondary dyslipidemias or acquired causes. Primary usually involves certain genes. That's why most of the primary will be familial hyperlipidemias or familial dyslipidemias. So I'm going to classify familial further into problems that are related to LDL, problems that are related to VLDL, problems that are related to triglycerides, problems that are related to remnants, and problems that are related to ApoA. That's how I'm going to classify. We'll start with the LDL problems. LDL problems can be due to problems in the LDL receptor, which is usually inherited as a codominant trait, but in exam you can write autosomal dominant also, no harm. Or it can be due to gain of function mutation of PCSK9. Whether loss of function mutation of LDL receptor or gain of function mutation of PCSK9, both are going to result in reduced concentration of LDL receptor on the hepatocyte surface in the liver. Because PCSK9 is the one that down-regulates the LDL receptor, as we saw in the previous slides itself. So more PCSK9 activity means more down-regulation of LDL receptor, resulting in reduced LDL receptor on the surface, resulting in reduced LDL take-up by the liver, resulting in more LDL circulating in the blood, resulting in more risk of atherosclerosis and early cardiovascular disease risk. Or it can be gain of function mutations in the ApoB100 gene, more production of ApoB100, more ApoB proteins, more badness. That's what it happens. Clear? So problems in VLDL can be due to problems in USF1 and related genes. That is what is thought to be the reason for increased production of VLDL. It results in a disorder called familial combined hyperlipidemia, FCH. And problems in triglycerides can be due to lipoprotein lipase problem, or it can be due to a protein called GPI1, HBP1. That's called a glycosyl phosphatidyl inositol, hepatocyte binding protein 1. So this is the protein that is very, very important for pushing the lipoprotein lipase from inside the cells to outside the cell, so that they can act and extract the free fatty acids from the triglycerides of VLDL or chylomicron. So if this is defective, GPI HBP1 protein is defective, this is also like a defective lipoprotein lipase only, and that is the reason why you can categorize under the heading of triglyceride issue. Or it can be an ApoC2 problem. As I told you before, C2 is very, very important for stimulating this lipoprotein lipase. If that doesn't happen, the chylomicrons and VLDL cannot be metabolized, which will result in increased amounts of triglycerides and chylomicrons in the body. And problems with remnants will be usually due to ApoE defects. Clear? ApoE is a very, very important apolipoprotein that serves as a ligand for the remnant receptor in the liver. So obviously, ApoE problems, the liver cannot recognize these remnants, resulting in increased remnants in the blood. So that results in remnant disease or broad beta disease, increased circulating remnants in the body. And ApoA problems can be due to ApoA1 defects, where the patients will have low HDL, and the patients can have ABCA1 transporter defects, resulting in Tangiers disease, which I told you already. And patients may have LCAT deficiencies, lecithin cholesterol acyl transferase deficiency, that can result in low HDL levels as well. So all these things can result in premature atherosclerotic cardiovascular disease. So remember, this first two, LDL and VLDL problems, will result in increased LDL in the patient, and this VLDL problems and triglyceride problems will have increased triglycerides. This VLDL problems, triglyceride problems and remnant disease problems will have increased triglycerides with them. At the same time, this ApoA problems are going to have reduced levels of HDL in the body. Clear? So these are going to be the major problems with relation to this familial dyslipidemias. First, let us dissect the important types of familial dyslipidemias. The first one is the LDL problems. The most important is the LDL receptor issue. And these problems result in a group of disorders called familial hyperlipidemia. And this familial hyperlipidemia can be homozygous or heterozygous. Heterozygous, only one gene is affected. Homozygous, both the genes are affected. Naturally, this heterozygous is going to be less severe compared to that of homozygous, where they're going to have a extremely severe form of the disease. Like they will have a very, very early heart attacks, like in childhood, like 9 years, 12 years, they might have a heart attack and a myocardial infarction and death. And it's very difficult to treat as well. So first, let us see what will be the features of heterozygous form of familial hyperlipidemia, where they're going to have a very, very high level of LDL. Usually there will be increased total cholesterol of usually levels 250 to 400. They usually tend to have an increased LDL of more than 155 usually. It can be like 200, 250 also. They tend to have xanthomas, and they also tend to have a early coronary artery disease, typically in the age of 30 to 60 years. Somewhere in the age of 30 to 60 years, they tend to have a coronary artery disease. Remember, what do you mean by young CAD or early coronary artery disease or early cardiovascular disease? It is defined as males if they are affected before 55 years of age, and females if they are affected before 65 years of age by a major cardiovascular event like stroke or myocardial infarction. That is what we refer to as a early cardiovascular disease, early CAD. And at the same time, these patients tend to have an incidence of approximately 1 in 200 to 300 in the community, typically in the Caucasian population, which is quite, like not so common or not so uncommon. It's a decent amount of incidence is there. And what about this homozygous group? Homozygous group tends to be extremely severe, but they tend to be very, very rare. Their incidence is approximately only 1 in 300,000 to 400,000, which means 1 in 3 lakhs to 4 lakhs, 1 in half a million approximately. Very rare incidence, not so common at all, but they tend to be extremely severe. And their cholesterol levels tends to be extremely high in the range of 600, 700. They usually tend to be more than 400 to 500. Very, very early coronary artery disease. Before the puberty itself, they can get an MI. Then as I told you, this USF1 issues will result in VLDL problems, results in a problem called familial combined hyperlipidemia, where the patient tend to have both elevated LDL as well as elevated triglycerides. And these mutations will result in overproduction of VLDL. Overproduction of VLDL. And their incidence is quite common in the community, approximately 1 to 2% incidence overall. And at the same time, the cholesterol levels are little variable because the cholesterol levels surprisingly can be completely normal in these individuals. But they tend to have an increased LDL and triglyceride more than what like other community people tends to have. And problems with increased triglyceride are lipoprotein lipase deficiencies, GPI, HBP1 or ApoC2 deficiencies, where most of these problems tend to produce a disorder called hyperchylomicronemia. Hyperchylomicronemia, where they tend to have extremely high triglycerides. And because of the extremely high amount of chylomicrons and triglycerides in the serum, they tend to have a type of serum called lipemic serum, where when you take the blood and extract the serum, that tends to be a little bit like fat-like lipemic serum. And usually they are not associated with any cardiovascular risk, but definitely they are associated with very high risk of recurrent pancreatitis. If you don't note this disorder, there is a high chance of developing pancreatitis again and again, and usually the death will be due to pancreatitis in these patients only. So how can you grade the risk of pancreatitis based on triglycerides? So the triglycerides are less than 500. Usually have only mild risk of pancreatitis. Normal triglycerides is less than 150. If the amount of triglycerides are 150 to 500, mild risk of pancreatitis. If it's in the range of 500 to 1000, you have a moderate risk of pancreatitis. Anything more than 1000 means it's high risk of pancreatitis, severe risk. It's a severe hypertriglyceridemia. Usually patients with familial causes and hyperchylomicronemia tend to come with severe hypertriglyceridemia only. Clear? At the same time, these patients may have hepatosplenomegaly because of high triglyceride processing, and these patients can be treated with fibrates. These fibrates are a group of anti-dyslipidemic drugs that are very, very important in treating hypertriglyceridemia. And sometimes these fibrates may not be enough to reduce the triglycerides. You might be needing some exorbitant procedures like plasmapheresis, and even gene therapy is underway for treatment of this hyperchylomicronemia. But remember, plasmapheresis can be used in exceptionally severe cases. Fine? All right. What about this remnant disease? As I told you, remnant disease will have problems in the ApoE gene, typically in the ApoE4 allele. That is what is going to result in the problem due to remnant disease. And in remnant disease, as I told you, you will have elevated triglycerides and elevated total cholesterol, but LDL levels are variable, but tends to have elevated total cholesterol and elevated triglycerides. And remnant disease patients also tend to have a elevated IDL and elevated chylomicron remnant, and that is the basis of having elevated total cholesterol in these patients, elevated chylomicron remnant, and they tend to have a late CAD risk. Still they have a CAD risk, but they tend to happen late, a little late, not very early. And ApoA problems, ApoA1 issues, they have obviously, as I said, very low HDL, and they tend to have a increased CAD risk because of rapid HDL clearance. Rapid HDL clearance. And about ABCA1 problem, you are going to result in a disease called Tanger's disease. Here ApoA1 protein will be there, but they cannot take up the cholesterol from the periphery, because to take up the cholesterol from the periphery, you need this ABCA1. If this is defective, you will result in reduced amount of HDL. At the same time, there will be increased cardiovascular risk, increased CAD risk, and you might get a early death due to myocardial infarction, because you cannot remove the cholesterol from the plaques. And at the same time, they have a very characteristic manifestation called yellow tonsils or yellow-orange tonsils. And because of the cholesterol that is deposited in the tonsils, which cannot be removed by HDL, this cholesterol is what that is seen as this yellow discoloration of the tonsils. And at the same time, this yellow discoloration of the tonsils with cholesterol plaques are also referred to as something called a tonsillar xanthomas. So any dyslipidemia in exam that has association with tonsils, go for Tanger's disease. Very, very rare disease, but still it's important to understand for exams. And we have LCAT deficiency, less than cholesterol acyltransferase deficiency, where these patients tend to have lower HDL because formation of mature HDL is dependent on this LCAT enzyme. But if you do not have LCAT, mature HDL formation will not happen. So you'll have a reduced HDL, but CAD risk is variable. CAD risk is variable, but they tend to have HDL of less than 10 in fact, but CAD risk is variable. That questions the importance of HDL. Remember, just presence of high HDL does not protect you from the cardiovascular risk, or just a mere presence of low HDL does not tell you that definitely you will get a cardiovascular risk. The most important element is the LDL. That's what I am substantiating again and again. HDL, yes, it's beneficial, but the LDL is the most important, to be honest. But CAD risk is variable because even though HDL level is low, still there is some amount of reverse cholesterol transport that is happening in the periphery through the ApoA1 proteins. So yes, CAD risk is variable here. And interestingly, there is one more disease that is associated with early cardiovascular risk, but they may have a normal lipid profile, that is called a familial cytosterolemia. You know what is happening here? Here, the early cardiovascular risk is due to increased absorption of plant sterols, which should normally be eliminated through the ABC G5-G8 transporter. So that is the problem here, defective ABC G5-G8 transporter. So suspect this familial cytosterolemia, especially when you have a relatively normal lipid profile with early cardiovascular disease. So you have to specifically test for the plant sterols in the blood. So ABC G5-G8 transporter. Then we are moving on to the secondary or acquired causes. Secondary causes are usually due to obesity. Very commonly, obesity increases the triglycerides and lowers the HDL. And patients with diabetes mellitus, especially type 2 diabetes and insulin resistance, they tend to have the same profile, like elevated triglycerides and low HDL. Apart from that, cancer treatment survivors are known to have dyslipidemia. So this is probably due to radiotherapy they receive, especially for the cranial cavity, which can result in development of hypothalamic obesity, and that could be the reason for dyslipidemia, or use of various drugs like dexamethasone and other corticosteroids during cancer treatment. That could be the reason for dyslipidemia in these guys. And at the same time, there are a lot of drugs, whole lot of drugs that can produce dyslipidemia. Like for example, starting from your oral contraceptive pills and estrogens and progestogens. Then we have beta blockers, thiazide drugs, antiretroviral therapy that is used for HIV/AIDS patients. Then alcohol, calcineurin inhibitors like cyclosporin. Many different drugs are implicated. Even pioglitazone has been implicated to increase the LDL levels, and SGLT inhibitors like canagliflozin is supposed to increase LDL levels according to studies, but we don't know really whether this effect is real or not. But many drugs can do that. But on the other hand, it's very important to know the effect of alcohol. Alcohol is going to increase the triglyceride as well as it can increase the HDL, and this HDL increasing effect of alcohol is thought to be one of the reasons why studies claim that moderate amounts of alcohol consumption is associated with cardioprotective effect rather than an increased atherosclerotic cardiovascular disease risk. Similarly, these estrogens, beta blockers, thiazides, ART drugs, all these things generally tend to elevate triglyceride more than the other components of the lipid profile. Calcineurin inhibitors, variable, cyclosporin, variable, but this estrogens, beta blockers, progestogen, thiazides, ART, they tend to increase the triglycerides rather than the affecting other components of the lipid profile. Then it can be due to renal or hepatic disease. Renal disease, you have to give special preference to nephrotic syndrome, which is very typically associated with hyperlipidemia, especially increased LDL, and that is also going to pose more risk for these patients to develop myocardial infarction. Apart from that, CKD patients, because of the inflammation they have, for the same level of lipid, CKD patients are going to have more cardiovascular risk compared to normal patients. That's also a very important point. So if I am having a LDL of 110 and CKD patients having LDL of 110, CKD patients for the same level of LDL, they are having more and more cardiovascular risk because their vascular injury and inflammation is too much compared to that of the normal peers. So that is why that point is also important to know. And hepatic disease in the sense with special preference to biliary cirrhosis and cholestasis, and they can elevate the triglyceride levels. I mean, they can elevate the cholesterol levels like anything, especially they will increase the remnants. And the importance of this in exams comes in the form of primary biliary cirrhosis, where many of these patients will have xanthelasma, very, very important marker of a primary biliary cirrhosis as far as hepatology is concerned. So they will increase the remnants. Remnants will cause that xanthelasma. Because whenever in a liver disease, you cannot take up this remnants properly. Remnant receptor will be defective in liver disease, especially cholestasis, so they cannot take up this chylomicron remnant and ideal, VLDL remnant. Then it can be due to hypothyroidism, endocrine problem. You know, hypothyroidism will have deficient LDL receptors because thyroxine stimulates the expression of LDL receptors on the hepatocyte surface. But hypothyroidism means low thyroxine. There will be a lower expression of LDL receptors on the liver surface, resulting in more circulating LDL and hyperlipidemia. So we have understood about some of the important secondary causes of dyslipidemia as well. With this, we'll be moving on to the clinical pointers towards dyslipidemia or probably a familial hyperlipidemia. The first one is the elevated total cholesterol, especially if it is more than 240 milligrams per deciliter. You have to strongly suspect dyslipidemia, and especially familial cause has to be ruled out. And if the patient is having elevated LDL more than 160 with family history, or if the patient is having elevated LDL more than 190 irrespective of family history. Here the family history is not important. In these settings, dyslipidemia is sure, risk of cardiovascular death is sure, and if possible, please do evaluate for familial dyslipidemias also. Number 2, if the patient is having a history of premature atherosclerotic cardiovascular disease. The patient has premature atherosclerotic cardiovascular. What is the definition of premature ASCVD? If in their family, if any male had ASCVD less than 55 years of age, or any females in their family had ASCVD less than 65 years of age. So this is what we refer to as a premature atherosclerotic cardiovascular disease. And third, presence of xanthomas. And xanthomas can be of many types. One, it could be associated with increased LDL, certain xanthomas are associated, and certain xanthomas are associated with increased triglyceride, and certain xanthomas are associated with remnants. So what are the xanthomas that are associated with increased LDL? First one is the tendon xanthomas, which are present along the tendon, very commonly along the Achilles tendon. It can be seen in the extensor surface, dorsum of the hand also, in the knuckles and all you can see. That is characteristic of a tendon xanthoma. And number 2, you have a tuberous xanthoma, which will be seen in the high friction areas, like in the elbows, near the olecranon process, in the extensor surface, near the patella. These are some of the examples of sites where you can see these tuberous xanthomas. And number 3, you can have intertriginous xanthomas, very common in the web spaces. So that's very specific for high LDL, very rare also, but very specific for high LDL, which can be seen in familial hyperlipidemias, that homozygous and heterozygous forms, which I have described already. High triglycerides generally tend to produce a type of xanthomas called eruptive xanthomas, which will be very commonly seen in the buttocks and the shoulders, which I'll be showing the picture in some time. And others, you can have xanthelasma. This xanthelasma is important because it may or may not reflect hypercholesterolemia, may or may not be associated with hypercholesterolemia, which means presence of xanthelasma does not surely tell the patient should have high cholesterol and cardiovascular risk. So that's something you have to understand. If at all, if it's associated with hypercholesterolemia, they'll be associated with remnants, chylomicron and ideal remnants, VLDL remnants. Number 2, plain xanthomas. Plain xanthomas can be seen in many areas, but very classically seen in the palm. That's called palmar xanthomas. Very classical sign of a elevated remnants in the blood. Clear? These are some of the important xanthomas that you have to know for the exam. So let me show you some pictures of these xanthomas. Here you can see some example of a tendon xanthoma where you are seeing in the knuckles on the extensor surface. There is another example of a xanthoma here. This is an example of a xanthoma that you are seeing in the Achilles tendon. This is an example of a tuberous xanthoma. We are able to see xanthomas. These tuberous xanthomas can be multiple and they can coalesce to form a polypod appearance also. So that's what you are seeing here. It's in the elbow here. So that's a tuberous xanthoma. And this is an example of an intertriginous xanthoma where you are seeing in the web spaces. And this patient also has a tendon xanthoma associated. And this is an example of a xanthelasma where you can see this plaques near the eyelids, right? And this is an example of an eruptive xanthoma in the buttocks and the shoulder. Clear? Now we'll be moving on to the assessment of hypercholesterolemia. Our assessment generally starts with the total cholesterol. So, but remember the fact that total cholesterol has multiple fractions and they don't really correlate very nicely with your cardiovascular risk. So that's why total cholesterol needs to be subsequently evaluated, which is further broken down to HDL cholesterol and non-HDL cholesterol, which means the cholesterol that you see in the blood can be coming from either an HDL cholesterol or it can be coming from the non-HDL cholesterol as well. But what it signifies, this non-HDL cholesterol means the cholesterol that is present in ApoB group of lipoproteins, and this HDL cholesterol means the cholesterol that is seen in ApoA group of lipoproteins. Clear? Which means the amount of non-HDL cholesterol, if it's increased, that means more ApoB, it means more bad, which means it's going to increase the cardiovascular risk. So that is the reason why currently this non-HDL cholesterol is actually turning out to be an excellent screening test in epidemiological settings. So it's very easy to find out as well. So total cholesterol is equal to HDL plus non-HDL cholesterol. It's a simple formula. Suppose if you need this non-HDL cholesterol, it's a very simple formula again. Total cholesterol minus HDL is going to give rise to the non-HDL cholesterol. So which means whenever non-HDL cholesterol are elevated, it means more ApoB related proteins and more problems, more cardiovascular risk. That's why this non-HDL cholesterol measurement is an excellent screening test. At the same time, this measurement of total cholesterol, HDL and non-HDL, which is just a derivative of total cholesterol and HDL, does not need fasting. No fasting required. So you can take in any time of the day. Patient comes in, think about cardiovascular risk, take a total cholesterol and HDL sample, and you can measure non-HDL cholesterol, elevate non-HDL cholesterol, likely high cardiovascular risk. No fasting required. Beautiful. Right? So that is one of the important advantages and why it is one of the very good screening tests right now. But the problem is non-HDL cholesterol alone will not correlate properly with the cardiovascular risk. It's the important fraction of non-HDL cholesterol that's going to correlate with cardiovascular risk, that is the LDL. But non-HDL cholesterol also has other fractions like intermediate density lipoprotein and VLDL. Clear? But LDL is the one that is a powerful and the strongest correlation and association with cardiovascular risk. So we need that LDL to measure that. So non-HDL is like a funnel. Like you do a non-HDL screening test, screen them and put into a funnel. When elevated non-HDL is there, so those patients you will be doing LDL further, LDL analysis further. So to measure LDL, you have two different ways to measure LDL. One is, of course, direct measurement of LDL is there, which is rarely done by many laboratories. But what they really do is calculated LDL or derived LDL. That's what they do. This is the most famous in all the laboratories, including clinical trials, where they are going to use a very famous equation called Friedewald equation. It's a very simple equation. It utilizes the common principle called total cholesterol is equal to HDL plus non-HDL cholesterol. And when you further break down the non-HDL, you can tell total cholesterol equal to HDL plus LDL plus VLDL. They usually eliminate IDL because they form a very, very, very small fraction. So you can further tell the fact that if you want to know LDL, you can write like total cholesterol minus HDL minus VLDL. Very simple. But you know the total cholesterol and HDL already. But how will you find out LDL without knowing VLDL? To understand this VLDL, we have one intelligent calculation. How much will be the VLDL? It tells you triglyceride by 5 will tell you the VLDL, which means you need only 3 measurements. You need a total cholesterol measurement, you need a HDL measurement, and you need a triglyceride measurement. And with this you can find out the LDL and VLDL values also, which means it is cost effective. You don't measure the VLDL and LDL actually, and you measure only 3 components, which means it's going to be very cost effective. But one problem is the fact that it's going to be needing one important prerequisite, that is it needs fasting sample. Why? Because this calculation is based on triglycerides. But first of all, wait on. So how will you use this triglyceride by 5 formula? So this is where that 80-20 rule comes. So we know that VLDL is composed of 80% of triglycerides and 20% of cholesterol, which means 1/5 of the triglyceride that you are seeing actually in the blood is actually the cholesterol that is coming from the VLDL. So 1/5 of triglycerides, that is 20%, is actually the cholesterol that is coming from the VLDL. So that is the reason why you make this triglyceride by 5 formula for VLDL assessment. But it needs fasting. It needs at least 12 hours of fasting if you want to measure LDL by Friedewald formula. Why you need fasting? Very simple. Because during fasting, your triglycerides in the blood is going to be coming only from VLDL. It's an endogenous production, that's all. But in a fed state, if a patient has taken a meal, this triglyceride has 2 sources now. It can come from VLDL and it can come from chylomicrons as well. So that is the reason you need fasting here. Suppose if you take sample in a fed state, what will happen? So if you take a sample in a fed state, the Friedewald formula tells LDL is equal to total cholesterol minus HDL minus VLDL, that is triglyceride by 5. Suppose if you are using a sample from a fed state, your triglyceride level will be very high, falsely high, because the triglycerides are now coming from the chylomicrons as well. So this will increase this value, resulting in a falsely low level of LDL. So that is why when you are using a Friedewald formula, you should not use a fed sample. You should always use a fasting sample, and the patient should be in at least 12 hours of fasting, which is very, very important. But what are the advantages of direct sample? Direct sample, you need not have fasting because you're directly measuring the LDL. But the problem with the direct sample is it is not validated. It is not yet validated, especially in the clinical trials. It is not yet validated in the clinical trials. For example, the ACC/AHA guidelines, whatever you see, the LDL values they mention are all based on the calculated LDL only. They are not based on the direct measurements at all. So that is why universally there should be a standard. So that's why they use this calculated LDL by Friedewald formula. And all the guidelines, including algorithm and treatment, are based on the Friedewald equation only. They are not based on the direct measurements. And to be honest, there will be a very big discrepancy between direct measurements and calculated measurements whenever you do. But to be standardized and to use in low resource settings also, they use only the calculated LDL for that matters. Remember, advantage of Friedewald formula, very cost effective, universal. Even the guidelines are using the calculated LDL values only to standardize the LDL measurements. But one problem is it needs a fasting sample. That's the only issue. Apart from that, Friedewald formula is the standard right now. But Friedewald formula will be unreliable. Friedewald formula is going to be unreliable in these settings. First setting, obviously it's in a non-fasting sample. If you don't have a 12-hour fasting sample, it will be unreliable. Number 2, if the patient is having some other problems like hyperchylomicronemia, especially if the triglyceride levels are more than 400, this Friedewald formula becomes unreliable because there is some other problem like hyperchylomicronemia in the patient that might be elevating the triglycerides even in fasting state. So it might not be reliable at that time. And number 3, if the LDL levels are less than 70. So if the actual LDL levels are less than 70, and that's not very important because LDL less than 70 means has no importance in clinical practice. But anyways, if the LDL levels are less than 70, the actual LDL levels that measured by Friedewald formula may be little bit unreliable. At the same time, you have to understand about the variabilities in the measurement. There could be 5 to 10% of interpersonal variability and 10 to 15% of laboratory variability between samples. And the variability is more with HDL. Variability is more with HDL because HDL values show more variability between samples compared to that of the other LDL or triglyceride fraction. And similarly, there is one important assay interference factor is there. We have to note about this as well. There is one thing that interferes with the assay for your cholesterol. That is very importantly your monoclonal antibodies, especially in the setting of multiple myeloma. These antibodies, when they combine with LDL, they can falsely show very, very high LDL levels in the setting of monoclonal antibodies against LDL. And that is the reason why multiple myeloma can be sometimes associated with extremely high LDL levels. Remember, how we can identify? Whenever the patient comes with extremely high LDL levels like 600, 700, but patient is not having any cardiovascular problem, patient is not having any xanthoma, you can suspect the presence of monoclonal antibodies as a cause of falsely elevated LDL. So this is due to assay interference. Let's complete the assessment with one important upcoming fact called small dense LDL fact, which is going to have a relatively high risk of cardiovascular disease compared to the usual LDL. So what is the concept of small dense LDL? First, let us understand what you mean by atherosclerosis and how it happens. So these are the endothelial cells which have small gaps in between them. The fenestration size depends on where the endothelial cells are, and they generally tend to be very small. And this is the blood, for that matter, blood flow in the capillaries and the vessels. And what really happens is this LDL molecules are smaller so that they will be able to penetrate underneath the endothelium. They can go through these gaps and they can get deposited under the endothelium, and they can deposit cholesterol under the endothelium. And this cholesterol under the endothelium is an attractant for macrophages. And these macrophages, once they engulf this cholesterol, they are going to become foam cells. Clear? So once they take up sufficient amount of cholesterol and they oxidize this cholesterol to produce oxidized LDL, and this will result in some inflammatory reaction inside the macrophages, which is going to produce some inflammatory mediators like tumor necrosis factor alpha, IL-1, fibrinogen, and IL-6. And this inflammatory mediators and cytokines will attract the smooth muscle cells to the local area. Smooth muscle cells to the local area. And there will be smooth muscle proliferation. And this is how atherosclerotic plaque starts to develop, and they start to expand as well. Because of smooth muscle proliferation, more and more macrophages will come into that area, and they start expanding. And one day they will rupture and they will produce MI and cardiovascular death. So the fact that this LDL is able to penetrate the endothelium is because they are small. And for the same reason, HDL is also associated with reverse cholesterol transport, because HDL is even more smaller, so that they can come into these areas very easily, interact with these macrophages through this ABCA1 transporter and its ApoA1 molecule on the HDL, so that they can suck the cholesterol out of the macrophage and they can take it back to the liver in a process called reverse cholesterol transport. That's why HDL is beneficial and LDL is harmful. But you know, the smaller the size of the LDL, more is going to be the problem. So that is the concept behind the small dense LDL. The small dense LDL particles are associated with specific disorders like diabetes and obesity, even though the diabetes is the most important. And that is the reason why patients who are suffering from diabetes mellitus have heightened cardiovascular risk for the same level of cholesterol. For example, 110 milligrams per deciliter may be the LDL levels, but the effects may be different for small dense LDL than a usual LDL. Which means for the same 110 milligrams per deciliter, you will have a more number of LDL particles, because in small dense LDL, the number of LDL will be more because the size is very, very small for the same amount of cholesterol. That is why there is increased ASCVD risk for the same number compared to that of other individuals. Clear? So that is why there are some experimental instruments that measure the actual LDL number. So this is the way to get rid of that problem. Measure the LDL number. This is one way. Second way is to find out the ApoB. So these are the two ways which can to an extent correlate with the concept of this small dense LDL, but still it could be a very important MCQ for your institute exams, where you have to know about this small dense LDL, where for the same amount of LDL, they produce more cardiovascular risk compared to that of the usual LDL particles. We have actually completed the assessment, and now actually we have to move on to the treatment of this lipid disorders. Treatment is based on this ACHA 2019 guidelines, who has completely revised the treatment in the last 3-4 years. So treatment will be based on the statin use and whom to use statins and whom not to use statins. That is the basic crux of this treatment guidelines. First, we'll see the algorithm, then we'll move on to the individual drugs that are used in the treatment of lipid disorders. First, treatment-wise, the ACHA divides the patient into 2 categories, broad categories. One, those that are intended to give primary prevention. Those guys that need primary prevention, you have some indications for them. And those guys who will be needing secondary prevention. So what do you mean by primary prevention and secondary prevention? Primary prevention means these guys will not have any evidence of atherosclerotic cardiovascular disease in the past or in the present. And secondary prevention means those guys who have evidence of atherosclerotic cardiovascular disease either in the past or they're currently having some evidence of ASCVD. What do you mean by ASCVD first of all? Atherosclerotic cardiovascular disease means there should be some problem in the body due to atherosclerosis, like your coronary artery disease, MI angina, your cerebrovascular disease like stroke and transient ischemic attacks, or a peripheral vascular disease like peripheral arterial disease, where the ankle brachial index will be less than 7 and there will be limb claudication. Anyways, these are the evidences of atherosclerotic cardiovascular disease. And the targets are also different. For example, if you decide to treat these patients for primary prevention, the targets are actually based on LDL cholesterol. So the targets must be LDL cholesterol less than 100 in these guys, and non-HDL cholesterol must be less than 130. Similarly, targets for secondary prevention are different. If you start treatment in these patients should be maintained at a LDL of less than 70 because they already have a disease, so we need a even more lesser LDL. And non-HDL cholesterol of less than 130, less than 100. Clear? So these are the targets. So anyways, you don't treat all the guys for primary prevention. There are selected group of patients who are going to target and you are going to treat. So this I can further divide into those individuals who can be straight away started with treatment with statins, no need of any further assessment. Clear? So no further assessment. Straight away you can start with statin treatment if these indications are there. First is anyone who is having LDL more than 190. LDL cholesterol more than 190 is a straightforward indication. Any patient with LDL more than 190, no further assessment is needed, no risk assessment is needed. Straight away you can start with statins. And very importantly, these patients has to be started with high intensity statins, the details of which I'll tell you in some time. What do you mean by high intensity, low intensity and moderate intensity? And these patients need high intensity statins and they are at extremely high cardiovascular risk. Suppose if these high intensity statins are not responding, suppose if your targets are not reached with high intensity statins, I told you the targets already, if these targets are not reached with high intensity statins, then you can switch to other group of drugs and you can add other group of drugs like ezetimibe, which is a intestinal sterol transporter inhibitor, which I told you multiple times already, or you can give a PCSK9 inhibitor, where PCSK9 is the protein that downregulates the LDL receptor. Giving this PCSK9 inhibitors will actually upregulate the LDL receptor, resulting in more LDL capture by the liver, resulting in lesser circulating LDL. That's the idea. So second group of individuals who don't need any further assessment is the guys who have diabetes mellitus, and if their age is more than 40, specifically according to the guideline, age 40 to 75, but anyone more than 40 years of age and having diabetes mellitus, you can start with statins as primary prevention straight away. And what statin you will start? You can start either a moderate intensity statin or a high intensity statin, depending on the cardiovascular risk. If low cardiovascular risk, you can start moderate intensity statin. If high cardiovascular risk, then you can start a high intensity statin. But this is highly doubtful and the trial results are not having good quality evidence, but in general, it's better to start with high intensity statins itself. But okay, patients may not tolerate high intensity statins straight away. So in those individuals, and especially if they are having low cardiovascular risk, then you can start with moderate intensity statins as well. And second group of individuals are others who need further risk assessment. What I'm telling here others is the fact that those who need further risk assessment, and the indication will be based on the age, And if the age is 0 to 19, or if the age is 20 to 39, or if the age of the patient is more than 40, for trial purpose, we can keep it as 40 to 75. More than 75, always consider using statin. That's it. If it is 0 to 19, means you can start with statins if the patient is having evidence of familial hyperlipidemia. That's it, nothing else. 20 to 39, you can start with statins if the patient is having LDL levels of more than 160 plus family history of premature atherosclerotic cardiovascular disease. I already told you what do you mean by premature ASCVD, males less than 55 years and females less than 65 years if they have evidence of ASCVD. That's what we refer to as a premature ASCVD in the family. If it's 40 to 75 years, then this is the area where you have to use the crucial 10-year cardiovascular risk calculator, which is available in the ACC-AHA website. You can access anytime. So based on whether the risk is less than 5%, or the risk is 5 to 7.5%, or the risk is 7.5 to 19.99%, that is less than 20% but more than 7.5, or if the risk is more than or equal to 20%. Obviously less than 5% means low risk. There is no treatment needed with statins, only lifestyle advice is needed. If it's more than 20%, which means it's a very high risk population and you need not only statins, you need a high intensity statin in this group. High intensity statins in this group. And 5 to 7.5% people will come under borderline risk, and these individuals will actually benefit from using moderate intensity statins. But it's doubtful, but still they might get benefit from moderate intensity statins. And those guys in the risk percentage of 7.5 to less than 20%, they are called intermediate risk patients. And they are again in the borderline, but still they will usually benefit from moderate intensity statins. Moderate intensity statins. Suppose if the risk is uncertain in this group. So if the risk is uncertain, you don't know the exact risk in these guys, or if the patient is not willing to use statins and they want additional assessment and the risk is uncertain. In general, risk enhancers is what we call. I will tell you what are the risk enhancers. So if the risk enhancers are absent, clearly absent in these guys, and patient also wants additional investigations and the risk is uncertain, then you can consider using a coronary artery calcium scoring. That's called a CT coronary artery calcium scoring. In CT coronary artery calcium scoring, if your score is 0, then it is better to not treat these individuals unless until there is a clear-cut cardiovascular risk. 1 to 99, better to treat, and anything 100 and above, definitely treat. So exam question can be framed based on who needs this CT coronary artery calcium scoring. Not all patients. Those patients who are not having LDL more than 20, those patients who are not having diabetes mellitus and age more than 40 to 75, and those patients who are having 10-year cardiovascular risk of more than 5% but less than 20%, especially from 7.5 to 19.9%. These guys are the ones, if the risk is uncertain, you can use the CT coronary artery calcium scoring in these guys. But if the risk is certain, if there is definite cardiovascular risk, or if the risk enhancers are present, surely you have to start with statins, no doubt about that. So what are the risk enhancers that we've been talking about till now? So there are some risk enhancers defined by ACHA guidelines. Number one is the LDL levels more than 160, patients who are having metabolic syndrome, severe obesity, insulin resistance, patients who are suffering from CKD. As I told you, these patients have very high risk. And the patients who are having family history of premature ASCVD, the definitions of which we have discussed multiple times. And patients who are having a high sensitive CRP, that is HSCRP levels of more than 2 milligrams per liter. Remember, this HSCRP is one of the very powerful non-lipid markers for screening of ASCVD. Remember, it's again a screening test, not powerful like LDL. LDL is the best always. So we have different types of markers. One is lipid markers and non-lipid markers. Non-lipid markers are basically inflammatory markers. These are markers of cardiovascular disease and risk. That's what you're talking about. So first, for screening, you can use total cholesterol by HDL ratio and non-HDL levels, non-HDL cholesterol levels. Both these are very powerful screening tests. And why they are used as screening? Because you can do it in a non-fasting sample itself. You don't need anything else, fasting for this. But for definitive risk assessment, you need LDL. LDL is the powerful and the definite cardiovascular risk marker, to be honest. HDL is not that important, but still, for certain settings, for defining metabolic syndrome, it might be important, but to an extent overall, HDL is not that important for us seeing the cardiovascular risk. LDL is the most powerful. And total cholesterol alone is not going to be powerful, and triglycerides has absolutely no cardiovascular risk. In the non-lipid markers, your hsCRP is a very, very, very good screening test, because hsCRP has a very high negative predictive value and it has a very good sensitivity but a poor specificity, which means high hsCRP does not tell you surely patient is at risk, but normal hsCRP can literally exclude a high cardiovascular risk patient. So that's why it's a very good screening test, but if it's more than 2 and the patient is not having any evidence of underlying inflammation, that suggests you of a ASCVD risk. Apart from that, if the patient is having lipoprotein A levels, this is also emerging as a very good marker, more than 50 milligrams per deciliter. That can be suggestive of a high cardiovascular risk, and patients who are having background of high risk ethnic group, high risk ethnicity like South Asians, best example, high risk ethnicity. And patients who are having an ankle brachial index of less than 0.9 suggestive of a peripheral vascular disease. These are the guys who can be definitely considered to start with statins for sure. Clear? Then we are moving on to the secondary prevention. Secondary prevention, all patients should receive lifestyle modification in the form of diet and a good amount of exercise and physical activity. But apart from that, you need some other treatment in the form of statins. You can classify as very high risk ASCVD, very high risk ASCVD, and those patients who are not at this group, not at very high risk ASCVD. So how will you define a very high risk ASCVD? So you can, the ACHA defines these patients as having multiple major events. Clear? So in the sense like multiple myocardial infarctions, multiple stroke and transient ischemic attacks, or having a symptomatic peripheral vascular disease. So this is what is defined as multiple major events, and these people will definitely come under very high risk ASCVD. Or patients who are having one major event, plus if they have any one of the following, like age more than 65, diabetes mellitus patients, hypertension patients, CKD patients, patients who are chronic smokers, and patients who have already received PCI or a CABG, coronary artery bypass surgery. And just one major event with any one of this, if the patient is having, then they will be deemed as very high risk ASCVD group. All others who are not coming under very high risk ASCVD will come under not at very high risk ASCVD only. So, there is nothing different in treatment. Both these patients have to be started with high risk, high intensity statins. There is no doubt about that. You will be starting with high intensity statins. Even this group of patients, you will be starting with high intensity statins, without a doubt. But if the targets are not reached, so what are the targets? You know the targets here. LDL must be maintained at less than 70 and non-HDL cholesterol must be less than 100. So that is the idea. But remember, the LDL levels in this very high risk ASCVD group is actually quite variable. ACCHA is still adamant in not changing this 70 cutoff, but there are a lot of other guidelines like ESC guidelines, and many Indian cardiologists try to keep a LDL cutoff of less than 55 as the target, because these patients, especially Indians, are having very, very high risk. So that's why very high risk ASCVD patients should be having LDL cutoff less than 50, according to many other guidelines apart from ACCHA, but ACCHA is still adamant in keeping the cutoff of less than 70. So if the LDL is still more than 70 after starting this high intensity statins, then you can add ezetimibe to your regimen, which is a NPC1L1 transporter inhibitor, steroid transporter inhibitor. If still the targets are not reached, next step is to add PCSK inhibitor. So this is what the guidelines are telling. But what is the difference from there? If the targets are not reached, here, remember, targets in patients who are not at very high risk ASCVD, but they are having clinical ASCVD, means in these patients targets will be LDL less than 70 only across any guideline in the world. So here the LDL target is definitely less than 70. There is no doubt about that. And non-HDL you can use. If you use it is less than 100. So these patients can be started with ezetimibe. But the only difference is here these patients are not eligible for PCSK inhibitors. PCSK inhibitors need not be used in this, guys. So what are the indications for PCSK inhibitors according to the latest guidelines? First indication, very high risk ASCVD patients who are not responding to high intensity statins. Number one indication. Targets are not reached with high intensity statins and the LDL remains more than 70. Second indication, patients for primary prevention, LDL more than 190 and the target LDL is not reached, that LDL more than 100 in a patient who is having LDL more than 190 for primary prevention. So these are the two indications for PCSK inhibitors. Clear? So this might be your exam question. So we are talking about lifestyle modification, isn't it? We are talking about a lot of lifestyle modification. What do you mean by this lifestyle modification? Which means it's a combination of diet as well as physical activity. So you have to define this lifestyle modification also while telling advice to the patient. So lifestyle modification means first diet, your fat content should be less than 30% of your total energy. Please try to increase the monounsaturated and polyunsaturated fatty acids in your diet. And fat, in the total energy that you are consuming, fat should contribute to less than 30%, very important point. Next, your saturated fat should contribute only to less than 10% of your total energy and there will be no trans fat. There should be no trans fat in your diet. That's very, very important. And next, physical activity. So usually they suggest moderate intensity physical activity for primary prevention and at least a light intensity to moderate intensity physical activity for secondary prevention. So minimum 45 minutes per day of light to moderate intensity physical activity is required, depending on what is the type of prevention, primary or secondary. So how can you classify your physical activity based on your duration of exercise or your type of exercise? So remember, sedentary activity is defined as energy expenditure less than 1.5 metabolic equivalents. For example, sitting, reclining in a chair, watching television will come under sedentary activity only. Light activities where you spend energy in the range of 1.6 to 2.9 metabolic equivalents. Best example is slow walking, walking slowly with your friends, or cooking, household activities. Basic household activities will come under light activity. Then you have a moderate intensity activity where energy expenditure will be in the range of 3.5 to 5.9 metabolic equivalents. 3 to 5.9. Metabolic equivalents, which includes, for example, a brisk walking, slow cycling at a rate of less than 10 miles per hour, and recreational swimming. Recreational swimming, just you are swimming for your own health. So in those conditions, you will be spending only moderate intensity exercise. And vigorous intensity exercise means you are spending more than 6 metabolic equivalents, includes jogging, running, cycling at the speed of more than 10 miles per hour, and swimming with laps, which means you are swimming for a race. So in those conditions, it will be defined as a vigorous intensity exercise. Fine. So this is how they define the physical activity. Apart from that, weight loss is definitely mandatory, especially if the patient is having obesity. So at least 5 to 10% of weight loss may be helpful in treating hypertension. It reduces systolic blood pressure because each kilogram of weight loss will reduce systolic blood pressure by 1 millimeter of mercury, which we'll be discussing in the hypertension chapter. And it can be helpful in reducing insulin resistance, and it can be helpful in reducing the cardiovascular risk as well. Then you have to definitely stop any form of nicotine, not only smoking, any form of tobacco and any form of nicotine has to be absolutely stopped. You have to increase the fiber in your diet. Usual recommended fiber in the diet is at least 6 to 12 grams. You can increase, no problem, if you want. Then try to increase more of vegetables and fruits because they contain sterols and they are more healthy. That's the reason. Sterols will reduce the absorption of cholesterol as well. And you can increase taking plant sterols, stanols and margarine. plant sterols, stanols, and margarine. Sterols are actually recommended at a dose of approximately 2 grams per day. I told you sterols compete with the NPC1L1 transporter for cholesterol, and they will reduce the cholesterol absorption. But anyway, sterols, even they go inside, they are going to come out through the ABC-G5-G8 transport. That's why sterols can be used as treatment for dyslipidemia and to reduce the cholesterol levels. But one important side effect is the GI side effect, and they can result in malabsorption of certain fat-related vitamins like A, D, E, K, and they are associated with 5 to 15% decline in the cholesterol levels overall. 5 to 15% decline in the cholesterol levels overall, including LDL cholesterol. So they are beneficial, but only problem is you have to cope up with the some malabsorption that will be happening with these plant sterols. Clear? So now we are moving on to the drug classes. So what are the drugs that are used in treating dyslipidemia? So I can write the drug class, then followed by its mechanism of action, then what will be the percentage decrease in the LDL, what will be the percentage increase in the HDL, and what will be the percentage decrease in the triglyceride by that particular drug class, and what will be the dosage of the drug, and finally side effects of the drug. So the first drug class we are going to talk about is obviously statins, without a doubt, and their mechanism of action is obviously HMG-CoA reductase inhibition. We know that. HMG-CoA reductase inhibitor, and the decline in the LDL by 20 to 60%. Increase in the HDL happens by approximately 5 to 10%, and decline in the triglycerides by approximately 10 to 25%. Clear? So this decline in the LDL by 20 to 60% depends on dosage of the statins and what is the type of the statin you are using. You can tell when you are using a low intensity statin, the decline in the LDL will be less than 30%. When you are using a moderate intensity statin, the decline will be in the range of 30 to 49%. And when you are using high intensity statin, the decline will be more than 50%, more than half from the baseline value. So this is actually the definition of low intensity versus moderate intensity versus high intensity statin. How the statins are able to reduce LDL? By inhibiting HMG-CoA reductase. This is a very good mechanism that goes on. So you have this cholesterol, and liver produces this substantial amount of cholesterol through endogenous synthesis of cholesterol through the HMG-CoA reductase pathway. Clear? So once you stop this HMG-CoA reductase mediated cholesterol production, your endogenous cholesterol will decline, which means you will result in reduced VLDL production and reduced LDL. So that's how they reduce LDL. So this is not the only mechanism, because the endogenous cholesterol is taking a hit. So the liver now needs more cholesterol. So what they try to do is they try to upregulate the LDL receptors. So which will result in taking up of more LDL for the purpose of more cholesterol that is needed for the system. So statins reduce LDL by multiple effects, but this decline in the LDL is associated with stability of the plaque. Stabilization of plaque, which means statins can stabilize the plaque, which means LDL is the most important factor for the plaque growth. So they can stabilize the plaque and they can prevent the further growth. And they can have anti-inflammatory effects. The anti-inflammatory effects is due to reduced LDL and not due to statins itself. If I tell anti-inflammatory in the plaque area, because LDL is the one that causes the macrophages to produce these inflammatory molecules, oxidized LDL. So if that is not there, if you reduce the levels, the movement into the plaque will reduce, the movement into the macrophages will reduce, so that they will produce reduced inflammation. That's what we call anti-inflammatory. So multiple effects are there. That's why statins are said to be pleiotropic in nature. Multiple effects. And what is the dose? I'll zoom in a little bit. Dose can be classified as what statins with what doses will be called as high intensity statins, and what statins with what doses will be called as moderate intensity statins, and what statins with what dose will contribute to low intensity statins. For our clinical practice, we need only high and moderate intensity. We are not going to use this low intensity statins, but still let me tell you. So atorvastatin at a dose of 40 to 80 milligram, rosuvastatin at a dose of 20 to 40 milligram, and simvastatin at a dose of 80 milligram are the ones that are going to contribute to the high intensity statins. But for Indian practice, we need atrovastatin 40 to 80 and rosuvastatin of 20 to 80. Moderate intensity statins, atrovastatin at a dose of 20 to 40, rosuvastatin at a dose of 5 to 10, simvastatin at a dose of 20 to 40 milligram. Apart from this, there are multiple other statins that can come under moderate and low intensity, but there are only 3 high intensity, atorvastatin, rosuvastatin and simvastatin, of which atrovas and rosuvastatin are most important. The most powerful statin is rosuvastatin only. And apart from that, lovastatin at a dose of 40 milligram and fluvastatin at a dose of 80 milligram and pravastatin at a dose of 40 to 80 milligram and pitavastatin at a dose of 2 to 4 milligram. This will come under moderate intensity statins. There is no low intensity dose for atorvastatin and rosuvastatin, but simvastatin at a dose of 10 milligram can act as a low intensity statin, and lovastatin at a dose of 20 milligram can act as a low intensity statin, and fluvastatin at a dose of 20 to 40 milligram can act as a low intensity statin, and pravastatin at a dose of 10 to 20 milligram can act as a low intensity statin, and pitavastatin at a dose of 1 milligram can act as a low intensity statin. But remember, whenever you are having a clinical ASCVD, very high risk or not at very high risk doesn't matter. Clinical ASCVD, LDL more than 190, or patients who are having diabetes mellitus and age more than 40 years with some CV risk, definitely you have to prefer high intensity statins only without a doubt. Either atorvas in the dose of 40 to 80 or rosuvastatin in the dose of 20 to 40. That's it. Side effects include transaminitis, elevated ALT, which can be seen in approximately 0.5 to 3% of the patients, and you might get myalgias, which is actually not so common, but it's overhyped in the practice. Less than 10%, less than 1 in 10 only will get myalgias, and they can result in rhabdomyolysis, which happens in less than 0.1%. Whenever the patient develops rhabdomyolysis due to statins, think about drug interactions. Patient might be getting some other drug that inhibits the statin metabolism, because statins are metabolized by CYP3A4, and this CYP3A4 can be inhibited by a variety of drugs, including azoles, drugs like HIV protease inhibitors. There are a whole lot of drugs which can inhibit this CYP3A4, and you have to be wary about this drug interaction. Especially when you are using statins for HIV patients, be a little careful. And they can produce necrotizing autoimmune myopathy. The incidence is unknown, but it's still been proven with patients who are taking statins, and this is associated with anti-200/100 antibodies. Remember, anti-HMG-CoA reductase antibodies are also there, which is associated with necrotizing autoimmune myopathy, but that is not related to statin-induced NAM. Statin-induced NAM will usually be associated with an antibody called anti-200/100, which we'll be discussing in detail in the rheumatology section. And they are going to increase the diabetes mellitus risk. And there is a new entity that is coming up that is called NODAS. NODAS means new onset diabetes after statin therapy. So after statin therapy, there is a definitive risk of getting diabetes. The risk is more with high dose, especially with high intensity statins. When you're taking at a full dose statin, the risk is more higher. So yes, that's a definitive risk. But don't think like this diabetes is going to be adverse. No, whenever you are having an ASCVD, the benefit you are going to get out of statins is going to be tremendous and unbeatable compared to the adverse effects of diabetes mellitus by using statins. So concretely, you can start with statins, no problem, and you can explain to the patients as well. And second drug class we are going to discuss is the ezetimibe. Very good drug, but limited by certain side effects. It is a NPC1L1 inhibitor. It's a sterol transport inhibitor, so which means they prevent the absorption of cholesterol. And decline in the LDL will happen by approximately 24%, but there will be no improvement in the HDL or no decline in the triglyceride as such. And the dose that is preferred is usually approximately 10 milligrams per day. That's the standard dose of ezetimibe. And usually, except for certain GI side effects, they are extremely well tolerated, no problem at all. Only some limited gastrointestinal side effects may be there. And third group of drug are the PCSK9 inhibitors. These are very upcoming drugs. Only the problem is currently it's too costly, like 17,000 in India per dose. But apart from that, they are very, very highly effective. To be honest, the maximum reduction in LDL you will obtain through PCSK9 inhibitors only. So not even statins. Statins were the powerful reducer of LDL among the oral group, but PCSK inhibitors may be just, more effective compared to that of the statins. But both are, you can keep it in the same boat. So PCSK inhibitors, obviously they work through PCSK inhibition. You know how it's going to work. LDL reduction happens by approximately 60%. Similar to statins, your HDL improvement will be happen by 5 to 10%, and triglyceride reduction may happen by 15 to 25%. You can see all the numbers are very, very similar to that of your high intensity statins. So almost similar, but slightly ahead of statins in compared to the efficacy. And dosage, you have two drugs under this group. One is called alirocumab. I'll put a little bit of zooming in. First drug is alirocumab, and second one is the evolocumab. So these are the two drugs that are currently approved. Alirocumab is used at a dose of 75 to 150 milligram 2 times a month. It means once in 2 weeks you will be using. Or you can use 300 milligram once in 4 weeks, Q4 weekly. Clear? I have actually started to use alirocumab in my practice, but effects are very good, but the only limiting factor is the cost, 17,000. That's the problem. And there are some patients who are ready to use it, especially who are having very high risk ASCVD, and those patients who are not tolerating statins, which means high intensity statins may not be taken, which means maximum tolerated dose you are giving, but still LDL more than 70 means you have to go with sDMIB or PCSK inhibitor, isn't it? It's not only about the high intensity statins if they are not responding and targets are not achieved. The maximum tolerable statins is what the key is. It's not, if suppose patients you are giving high intensity statins and they're not able to tolerate, you switch down to moderate intensity statins, but the LDL will become high. In those patients also you can use this sDMIB and PCSK inhibitors if the patient is having a very high risk ASCVD. Clear? So evolocumab can be given at a dose of either 140 milligram once in 2 weeks, or you can give a 420 milligram dose once in 4 weeks also. Clear? These are the two drugs that are available. Side effects as such, they can produce nasopharyngitis, URL-like symptoms, and they can produce some injection site reactions. That's all. Apart from that, they are little well tolerated. Then the next group of drugs are fibrates, not powerful for reducing LDL, but they are very powerful triglyceride lowering agents. They work by PPAR alpha agonism in the liver, and by having agonistic effect on PPAR alpha, that's a peroxisomal proliferator activator receptor alpha, they can reduce the hepatic free fatty acid output, which means they can reduce the hepatic lipase activity also, and they can reduce the hepatic free fatty acid output. That's how they work. And LDL lowering effect is only 5 to 15%, very less, not significant, and HDL increasing effect is approximately 5 to 15%, but triglyceride lowering effect is 35 to 50%, which means they are very powerful agents that can reduce the triglycerides dramatically. Remember, up to 50%, but they cannot reduce from 2000 to just 150 or 160. They can reduce 2000 to 1000, up to 50% they can reduce, but still this might not be enough in patients with familial hyperchylomicronemia, where they can have triglyceride of 2000, 3000 and all, lipemic serum. So, but still they are very good drugs for reducing the triglycerides. And dose, typically we will be using fenofibrate. The old drugs like clofibrate, bezofibrate are not used currently. We use only fenofibrate, and some countries use this gemfibrozil also. But anyway, fenofibrate is what is available everywhere in the world, and in India it's very, very popular, used at a dose of 40 to 160 milligram per day, and standard dose in adults is 160 milligram. That's what we prefer. And side effects, they can produce myalgia and myopathy. But remember, whenever you are going to use along with statins, the risk is even more higher, even more increased risk with statins. Statin use, concomitant statin use will increase the risk of myopathy and myalgia. And they can produce renal failure, increase serum creatinine. So these are the two side effects of fibrates that you have to know. And they can produce a little bit of heterotoxicity also, but that's not important for us. And omega-3 fatty acids, they're emerging as a very good treatment for lowering for lowering triglyceride especially, but they don't have good effect on LDL, but they can lower triglycerides, omega-3 fatty acids. What are the omega-3 fatty acids available? You have eicosapentaenoic acid and docosahexaenoic acid. EP and DHA are the two omega-3 fatty acids that you use. It's not just fish that contains this. You have to use this special formulations of tablets, then only it will be effective. So effect Mechanism of action, they reduce the hepatic VLDL production and they activate the lipoprotein lipase as well. Postprandial lipoprotein lipase will be activated. And the LDL lowering effect is not there actually. In fact, they can increase LDL by 5%, but that is insignificant. At the same time, they can increase HDL by 3%, but they can lower the triglycerides by 25 to 50%, which means they are very effective in lowering the triglycerides. You are going to take EPA, that is eicosapentaenoic acid, and DHA, that is docosahexaenoic acid. Minimum dose that is needed is at least 4 grams per day. Minimum 4 grams per day, if you take, then only they will be effective. These are fish oils, but they have taken a commercial form. Not just by taking fish, you will be getting this much amount of EPA and DHA. And there are no much side effects. They are well tolerated. Mild GI side effects may be there, but it's insignificant. And number 6, you can use some resins like cholestyramine. These are bile acid binding agents. These are bile acid binders. How they work? By binding with the bile, they will remove the cholesterol from the bile, because bile will be reabsorbed in the distal ileum and in the distal intestine, but that will be prevented by these bile acid binders. Bile contains a lot of cholesterol and lipids, and that will be lost in the stools. It's like wasting bile, wasting cholesterol. That's what it is. So they can reduce LDL by 10 to 20%, but they do not have any effect on increasing HDL or triglycerides. And they have to be taken at a very, very high dose, like 8 grams per day, and they are very poorly tolerated. These are the drugs that usually patients hate them usually. Very poorly tolerated drugs, and they produce severe GI side effects like diarrhea, cramping, malabsorption. Severe GI side effects will be there. At the same time, they can produce deficiencies of vitamins A, D, E, and K, because these are fat-soluble vitamins and they need bile to get absorbed, and they can produce clinical deficiencies of vitamin A, D, and E, and K, and they are very poorly tolerated as well, which means these are the least preferred therapy currently. We don't use this bile acid resins. There are some other drugs. We have discussed in detail about the commonly used drugs, and there are other drugs which can be used under selective circumstances like niacin. In fact, we don't use this niacin right now because of multiple reasons. The mechanism of action of niacin, we don't know. Probably due to CETP inhibition, we don't know, but still it's been proposed. But effect is, it increases HDL, and one of the powerful HDL increasing drugs is niacin. And they can lower LDL and triglyceride to an extent, but this HDL increasing activity is the prominent effect of niacin. But the problem is, even though they are increasing the HDL, this is not translating into clinical cardiovascular benefit, which means there will be no appreciable effect on cardiovascular outcomes. That is the reason this drug has become highly unpopular. Many trials have been run on niacin, but none of them have a decent benefit in cardiovascular outcome. With regards to cardiovascular outcome, that's why we don't use these drugs right now. Side effects are multiple. They can produce flushing, we know that, and they can produce myopathy, and they are heterotoxic as well. Liver dysfunction, heterotoxic as well. So a lot of side effects, increase HDL, but no clinical cardiovascular benefit, no effect on outcomes. That's why this has become a very unfavorable drug right now. The main reason why we don't use is that is no effect on cardiovascular outcomes. Multiple trials will be done, but no CV outcome benefit. That's the reason. And there is another drug called mipomersen. This is a very interesting drug. This has to be given as subcutaneous injection. What this drug contains is the fact that it is an antisense oligonucleotide. Antisense oligonucleotide against ApoB mRNA, which means this is actually a nucleotide sequence that goes into the cell and blocks the mRNA from getting translated. Clear? So if you want to describe in detail, we know the central dogma, isn't it? Central dogma in biology, where you have this DNA, which will be transcribed to mRNA, which will be further translated into proteins and resulting genetic expression, right? This is called the central dogma. So let us assume this is an ApoB mRNA, and you are giving a mipomersen. Mipomersen is an antisense oligonucleotide against this ApoB mRNA, a short sequence oligonucleotide. So that will bind with the ApoB mRNA. So whenever in your cell you have a double-stranded RNA, this will be usually destroyed. Which means when you give mipomersen, you don't translate this ApoB protein itself. The ApoB protein production itself will be reduced to a great extent, and that's how this mipomersen is going to work. But it's a oligonucleotide sequence, so it has to be given by subcutaneous injection only. That's the one problem. And they can reduce VLDL, and they can reduce LDL as well. What are the indications in refractory familial hyperlipidemia, where they don't respond to statin, they don't respond to even PCSK9 inhibitor? In those settings where very high LDL levels are there, in those settings you can use this mipomersen. Only side effect that you have to know is heterodoxity. Fine. These are available drugs. These are approved currently, mipomersen. And you have another drug called lomitapide. I mentioned about this drug already, lomitapide. Lomitapide is a MTP inhibitor, that is microsomal transfer protein inhibitor, which is very, very important for the production of chylomicrons as well as VLDL. MTP deficiency or defect will result, as I told you, in your A-beta lipoproteinemia. So this is the target for the drug, that is lomitapide. It's an oral drug used in refractory familial hyperlipidemia, where it is not responding to our routine therapy like statins and PCSK9 inhibitors, and side effect is heterodoxity. It is heterotoxic as well. Then you have a final drug called volanesorsen. Volanesorsen is another antisense oligonucleotide against a certain mRNA, but this time it will be against C3 mRNA, ApoC3 mRNA. So if you reduce the production of ApoC3, your VLDL will not be formed and chylomicrons will not be formed properly, which means this is very, very important for reducing the triglycerides. So that is how this drug has been designed for. So obviously it's an injection, subcutaneous injection, because it's a oligonucleotide that is present, and it is used in patients with refractory hypertriglyceridemia, especially familial hyperchylomicronemia. If the patient is having recurrent pancreatitis, you can use this drug, that is volanesorsen. So now what are the drugs that are used as injections? Injection drugs include PCSK9 inhibitors, mipomersen, and volanesorsen. PCSK9 inhibitors for LDL, mipomersen also for LDL, but volanesorsen for reducing triglycerides. Clear? So this is something which is very important to understand. Remaining all other drugs are oral drugs only, not injectable drugs. Then finally, how will you treat hyperchylomicronemia? Hyperchylomicronemia, where patients may have extremely high level of triglycerides, usually in the range of 2000s and 3000s. Usually it will be more than 1000, and the patients will have a lipemic serum. And many times their presentation will be like recurrent acute pancreatitis. That's how they present. Whenever you have a condition called recurrent acute pancreatitis, you have to rule out triglycerides. Patient coming with first attack of pancreatitis, nowadays we do triglycerides routinely. So, but if you miss this, they will be coming with recurrent acute pancreatitis. But remember, I have seen, in the last few months itself, I have seen 2 cases that came with a triglyceride of 3000 and 2000. So, acute pancreatitis, always do triglyceride. Don't forget to do that. It's very important. Calcium, triglyceride are very, very important in any case of acute pancreatitis. Hypercalcemia as well as hypertriglyceridemia can be associated with acute pancreatitis. They can cause acute pancreatitis. Anyways, recurrent acute pancreatitis is one of the important clinical features, and they can have eruptive xanthomas. As I told you, they can have a lipemic serum. But cardiovascular risk is questionable. Even at this level, they don't have that much cardiovascular risk. In fact, some studies tell no cardiovascular risk with even 1000, 2000 triglycerides. But how are you going to treat? Treatment for acute reduction and for chronic reduction of triglycerides. Acute reduction, you can use plasmapheresis, which are really good. They can reduce the triglycerides. But if your plasmapheresis is not available, plasma exchange is not available, then you can try a very cheaper option like insulin and dextrose therapy. Insulin can reduce triglycerides to a great extent. Very, very important point. Obviously, insulin, if you give, they'll go for hypoglycemia. To prevent that, we are giving dextrose. Insulin is a very good therapy. Usually start at a dose of 0.1 units per kilogram per hour. Insulin infusion can acutely reduce triglycerides. It can bring the triglycerides from thousands to 200 or 300 within a short span of time, within probably a day. So it's a very good therapy. Chronic reduction, obviously we are going to use fibrates, omega-3 fatty acids, and finally we have this volanesorsen in refractory cases. Clear? So these are the treatment options that are available for reducing the triglycerides. But remember, adding statins can be beneficial. Plus or minus you can add statins also, because statins also has some triglyceride lowering effect, especially if the patient has a little elevated LDL also, then definitely you can start with statins as well. So we have discussed in great depth and great detail about this lipid disorders, which are very, very important, especially the new ACC/AHA guidelines are very important for the exams. So with this, I will sign off with this particular chapter. It's a very long chapter, I know, but very important one. Please go through when you're having time. So let us move on to the next chapter on obesity.